السلام عليكم طلبتنا الأعزاء. Our lecture today will be an important topic, which is the bilirubin metabolism, which is one of the important function of the liver. The objective of this lecture is to define the different steps in the bilirubin metabolism and how can we differentiate the conjugated and unconjugated bilirubin. Then we will define the hyperbilirubinemia and jaundice and classify the jaundice into different types. And we will take example of the jaundice, which is the inherited hyperbilirubinemia, its type, and the cause in each type of this inherited hyperbilirubinemia. One of the most important functions of the liver is the processing and excretion of a substance into the bile or the urine. This process includes exogenous material or endogenous material. One of the very important subjects that the liver can handle and process is the heme waste product that is called bilirubin. The liver is the only organ that has the capacity to get rid of the body of this heme waste product. So if we have any damage to the liver, the bilirubin we cannot get rid of the bilirubin. So what is the bilirubin? It is the principal pigment in the bile. It is the end product of heme metabolism. So it is the heme metabolism waste product. Why it is important to get rid of it? Because if it remains in the body, it is toxic. From where we have this bilirubin, we have two main sources. 80% of the bilirubin come from the degradation of the RBC hemoglobin after the lifespan has been completed, and 20% of this bilirubin originate from other heme containing protein, and for example the myoglobin, and from ineffective erythropoiesis in the bone marrow. So as a result of this normal process, we will have the waste product that is called a bilirubin, and the liver is the only organ that can deal with it and excrete it from the body. And because it is processed in the liver, we can use it as a marker for liver disorder, and because it originates from the heme and RBC metabolism, we can use it also as a marker of a blood disorder. The lifespan of RBC is about 60 to 120 days. After that, the RBC will be phagocytosed by the macrophage in the reticular endothelial system, and then lyses to the RBC agar. It will give the hemoglobin, and the hemoglobin, from its name, it composed of two parts, the heme and the globin. The globin is a protein and it is composed of amino acid. It will be break down to give the amino acid, and then it will return back to the amino acid pool to synthesize more polypeptide and more protein. While the heme ring will be opened, and it will release iron and bilirubin. The bilirubin must be excreted because it is toxic, and the iron will be reused again. It will be transported by the transferrin and returned to the iron pool to be reused again for synthesis of a new RBC, new molecule of the hemoglobin, and the bilirubin must be excreted. This lecture mainly is how to deal with this bilirubin. Many organs are involved in bilirubin metabolism, started from the reticuloendothelial system, which is the site for the lysis, and the bloodstream, which will carry the released bilirubin to the liver. From the liver, it will pass to the intestine, and then it will be excreted in the feces, with a small portion excreted in the urine. if we look at the fate of the bilirubin, we will see that 80% of this bilirubin that originate from the RBC will be excreted in the feces. 80%, 2% will be excreted in the urine, and 80% will reabsorbed and recycled again to the enterohepatic circulation. After opening of the heme ring by the enzyme heme oxygenase, it will release a molecule called biliverdin. This biliverdin, by biliverdin reductase, will be converted to another compound that is called unconjugated bilirubin. This unconjugated is dangerous and dangerous waste product because it is water insoluble and lipid soluble, so it can pass to the blood-brain barrier, and especially in a neonate, and cause damage to the brain. And in adult, also it may precipitate and cause many disease. So the body normally get rid of it. This unconjugated bilirubin that is formed after the breaking of the hemoglobin heme molecule is because it is water insoluble, it needs a transport of protein to carry it to the liver, where it is the main site for processing and conjugation. The carrier protein in this case for the unconjugated bilirubin is the albumin. Why we need this process of carry the bilirubin that is unconjugated to the liver and conjugation? Because it cannot be removed from the body without conjugation. So the process of conjugation, the aim is to make it in a form that can be excreted from the body. We have the unconjugated bilirubin will bind to albumin, form bilirubin-albumin complex, and it will be transported to the liver. In the liver, the process of conjugation occur. Why we bound it to albumin? First, it is important to increase the solubility of unconjugated bilirubin because it is water insoluble. And second, by binding to albumin, the bilirubin, the unconjugated, it prevents it from diffusion back to the tissue and causing damage. Now, the unconjugated bilirubin that is released from the heme reach the liver. What happened in the liver? We have three important processes or three important steps. First of all, it must be uptaked. After uptake, it must be conjugated, and then it will be excreted into the bile. The unconjugated bilirubin, after binding to the albumin, will be uptaked by the liver cell, and then it will be bound to another it will be released from albumin and it will be picked up by another carrier protein in the liver, which is called the ligandin. Ligandin is found inside the hepatocyte and it is responsible for transporting the unconjugated bilirubin to the endoplasmic reticulum. So the unconjugated bilirubin albumin complex attached to the liver cell, then the liver cell, the albumin is removed, it's bound to ligandin. Ligandin carry the unconjugated bilirubin to the endoplasmic reticulum. Why? Because the conjugation site is in the endoplasmic reticulum. What happened? This is the most important step, which is the conjugation. We need an important enzyme. It is called the uradyl diphosphate glucuronidase transferase. It is very important because it mediates the binding of the bilirubin to two molecules of glucuronic acid to form the bilirubin diglucuronide. This step will make the bilirubin from water insoluble to water soluble. So now, by binding to bilirubin glucuronide, the bilirubin became water soluble, and now the next step is to be excreted in the from the hepatocyte into the bile canaliculi and then into the intestine. This process of conjugation It can be enhanced and induced by certain medication, for example, the phenobarbital. And one of the clinical application of this thing is that sometimes in the newborn baby, because he may be immature or the liver immature, so this process cannot occur in a proper way. So they give him phenobarbital in a calculated dose, and this will induce the UDP gluconyl transferase and convert the unconjugated bilirubin to conjugated bilirubin so that it can be excreted from the body. Otherwise, if it remain in high concentration in the body, it may precipitate in the brain and cause brain damage to the baby. Then it will pass the conjugated bilirubin. It will pass through the bile caniculi and through a common bile duct and pass to the intestine. Now, the bilirubin is in the intestine. What are the steps that occur in the intestine? We have certain type of bacteria, mainly in the lower part of the intestine. It will act on this bilirubin diglucuronide. It will cause hydrolysis, and then it will um, convert it to a product called mesobilirubin, and then mesobilirubinogen is reduced, and then will convert it to a very important molecule that is called urobilinogen. It's called urobilinogen. This is a colorless product. So this urobilinogen are then oxidized by another intestinal bacteria to give an important substance that is called stercobilin, which give the stool its characteristic brown color. So about 80% of the bilirubin will get rid from the body by the feces, and some of the 20%, most of these 20% that is remaining, it will reabsorbed back from the gut to the portal circulation, and then it will be recycled by the enterohepatic circulation, and a very small percentage will be filtered by the kidney and excreted in the urine. So finally, all of the bilirubin is conjugated, and about almost of it is eliminated in the feces. A small amount of the colorless product, the urobilinogen, is excreted in the urine, and as a result of all of these processes, the healthy adult has very low level of the total bilirubin, which range between 0.2 to 1 milligram per deciliter, and the majority is of this is unconjugated, that will be later conjugated and excreted from the body. So, if there is increase in the bilirubin in the blood, if we measure the bilirubin and it was high, it indicates that the process of bilirubin metabolism is defective. We will see where is the defect, whether in the liver or prior to the liver or post maybe due to obstruction. So the summary, it will be uptake, the bilirubin uptake by the liver, and this uptaking will be in the endoplasmic reticulum. It is conjugated with glucuronic acid. Then the enzyme that mediates this process is the UDP gluconyl transferase. The conjugated bilirubin is water soluble, secreted into the common bile duct to the intestine. In the intestine, it will convert it to urobilinogen, then oxidized to stercobilin. The urobilinogen is colorless. The stercobilin is colored. It gives the stool its characteristic brown color, and it will be excreted in the feces, the majority, and some will be reabsorbed and re-excreted again. Either a small amount will pass to the in the kidney, filtered by the kidney, and appear in the urine, the urobilin, or some will be recycled to the intestine. What happens if we have abnormality in bilirubin metabolism? The answer is we will have jaundice. So what is jaundice? It is defined as the yellow discoloration that result from excess amount of bilirubin or retention of bilirubin in the body. This yellow discoloration usually appear in the sclera of the eye, in the mucous membrane, and in the skin. Because many organs are involved in the bilirubin metabolism, so the causes of jaundice can be classified into prehepatic jaundice when the defect is before the liver, and we have the hepatic jaundice when there is abnormality in the liver parts that involved in bilirubin metabolism, which is the uptake of bilirubin, conjugation, and excretion, or sometimes we have what is called the post-hepatic jaundice when the defect is beyond the liver. The prehepatic also is called hemolytic jaundice. Why? Because usually it results from excessive production of bilirubin. The pathway of metabolism in this case is normal, but there is overload or there is overproduction of bilirubin. As in case of hemolysis, the amount of bilirubin that is produced will be more than the capacity of the liver to deal with. In this case, the liver is usually normal, and there's no obstruction, and there is a post hepatic, and with all the process that occur in the liver is also normal, but there is overproduction, so it takes time until the liver can deal with this excessive amount of bilirubin. In case of any type of anemia, whether autoimmune hemolytic anemia or in the newborn due to hemolytic disease of the newborn, or in case of sickle cell anemia, all these may lead to a prehepatic hemolytic jaundice, and because the conjugation is normal and there is no obstruction, the part of the bilirubin that is increased usually is the unconjugated bilirubin. So this type of jaundice is characterized by increase in the total bilirubin, increase in the unconjugated bilirubin, this is mainly the part that is increased, and the liver function test, all are the liver enzyme or other marker of liver function, all are normal. In this figure, the continuous line is the normal pathway, while the interrupted line is the alternative pathway. We will see that there be excessive amount of bilirubin produced before the liver, and this will be reflected on the urobilinogen, also will increase the urobilinogen that will be that appear in the urine will be also increased. The other type of the jaundice is the hepatic jaundice or the intrahepatic jaundice. We have three processes normally occur in the liver regarding bilirubin metabolism, which is the uptake of bilirubin, the conjugation, and the excretion. So if there is impairment of the liver, maybe due to hepatitis, or maybe any toxic drug-induced liver damage, or maybe cirrhosis, or drug-induced, for example, the paracetol and halothane poisoning, all may affect the liver function, so it will affect the ability of the liver to conjugate, uptake, and conjugate and excrete the bilirubin. So in this case, both the conjugate and unconjugated bilirubin will increase, the total bilirubin will increase, and both the conjugated and unconjugated will increase. And the other type, and usually this type, is accompanied by abnormality in the liver function test marker. The post-hepatic, in this case, there is no overproduction of bilirubin, and the liver processing of bilirubin, the uptake, conjugation, and the excretion is normal, but there is obstruction that prevent the bilirubin from reaching from the liver to the intestine, and as a result, it will increase, the total bilirubin will increase, and mainly the part that will be increased is the conjugated bilirubin. And because there is no bilirubin reaching to the intestine, there is no urobilinogen, no stercobilinogen, and the color of the stool will be pale. And as a result, there will be regurgitation of the bilirubin back to the circulation because it cannot pass in the intestine, and in this case, there will be increase in the urine color. It became tea color. So in case you see a patient with jaundice, what should you do to investigate his condition? You will send him for the measurement of the total serum bilirubin and the fractionation, which we measure the conjugated and unconjugated. In addition, measurement of the urinary bilirubin and urinary urobilinogen is very important because it can give an idea of the site of the defect. For example, the increase in the urobilinogen, it means that the pathway is open, but there is overproduction of the, and this indicate of the bilirubin, as in case of prehepatic jaundice, while in case of posthepatic jaundice, there may be complete obstruction and the urobilinogen may be absent in the or decrease in the urine. Normally, we don't have bilirubin in the urine, and if it increases, also it indicates certain type of jaundice. In addition to bilirubin, we can measure the amount of other marker, for example, the liver enzyme, the ALT and AST, which usually increase in case of hepatocellular jaundice, and other enzyme indicate that there is obstruction or cholestasis, which are the alkaline phosphatase and the gamma glutamyl transferase, usually increase in case of the patient have post-hepatic jaundice. How can urobilinogen measurement in the urine help to identify the type of the jaundice? Normally, urobilinogen appear in the urine, especially if it is concentrated, and the bilirubin doesn't appear. So if we found bilirubin in the urine of a patient, it is abnormal. When does the concentration of urobilinogen increase? If we have excess amount of bilirubin produced in case of prehepatic or hemolytic jaundice, then the large amount of bilirubin will enter to the intestine, and excessive amount will be converted to stercobilinogen, and more urobilinogen will produce, and as a result, more urobilinogen is absorbed and filtered by the kidney and appear in the urine. So the pathway all is open, but there is excessive amount of urobilinogen that is produced. Another condition when urobilinogen is increased in the urine, when the hepatic capacity to resecrete it is exceeded. So the amount that will be recycled will be less, and the amount that will appear in the filtered by the kidney will be increased, and there will be increase in the urine urobilinogen. So in case of jaundice, if we measure the conjugated bilirubin and in the blood, in case of prehepatic, it is normally absent, while it is increased in case of intrahepatic jaundice and posthepatic jaundice. In the prehepatic, normally it is unconjugated hyperbilirubinemia. The urine bilirubin also is absent in case of prehepatic jaundice. Normally, bilirubin doesn't appear in the urine. And in case of prehepatic, the pathway is open and normal, but there is excessive amount, so also bilirubin will not appear in the urine. While in case of intrahepatic jaundice, the urine bilirubin will present, and also in the posthepatic jaundice, the urine bilirubin will be present. Why? Because there will be back pressure. Because of the obstruction, it will pass to the circulation. More will be filtered of this bilirubin in the kidney, and it will appear in the urine. The urobilinogen is present in case of intrahepatic prehepatic. It will present in large amount. Also in case of intrahepatic, but in case of obstruction due to a stone or any other cause, for example, a tumor of the head or the pancreas that compressing the common bile duct, preventing bilirubin from passing from the liver to the intestine. Then in this condition, if there's complete obstruction, then urobilinogen will be absent from the urine. The other topic in this lecture will be about the inherited hyperbilirubinemia, which is defined as having jaundice or hyperbilirubinemia without any other detectable abnormality, and this occurs due to abnormality usually in the that is inherited or congenital. We have many syndrome. We have the Gilbert, the Crigler-Najjar, and we have Rotor and Dubin-Johnson syndrome. Each have its characteristic. Gilbert is very common. It is about 2 to 3% of the population may have this disease. There will be unconjugated hyperbilirubinemia, and the bilirubin, the increase in the bilirubin is usually mild. It is usually less than 5 milligram per ml per deciliter, and usually it's asymptomatic, and mainly this appear during a case of intercurrent illness or fasting or any stress on the body will make this more obvious. The total bilirubin usually range between 1.5 to 3 milligram per deciliter, and the defect is in this condition is the decrease in the expression of the enzyme that is conjugating enzyme, the UDP gluconeotransferase. So under normal condition, it can perform in a good way, but under stress condition or illness or fasting, the defect became more obvious. The defect is decrease in the expression of this conjugating enzyme, and to diagnose this disease, first we must exclude any other hemolytic disease that will lead to unconjugated hyperbilirubinemia, and other hepatic disorder all must be excluded, and the proper test is by genetic analysis to see that the level of the UDP gluconeotransferase is have show the decrease in the expression in this patient. Usually this is a benign condition. The other more serious cause of unconjugated also hyperbilirubinemia is the Crigler-Najjar syndrome. There will be a deficiency of uridyl gluconeotransferase enzyme, and in this condition we have two types. One is type 1, it's autosomal recessive, and the type 2 is autosomal dominant. And in this condition, this mutation results in low enzyme activity. The enzyme activity will be low, and the patient shows severe unconjugated hyperbilirubinemia. And if this was severe, it may lead to kernicterus, brain damage in the children because of this unconjugated hyperbilirubinemia, and the unconjugated hyperbilirubinemia usually is lipid soluble and water insoluble, so it can precipitate past the blood-brain barrier, precipitate in the brain, and lead to brain damage. These two examples, first two, the Gilbert and Crigler-Najjar was unconjugated. The other two are the conjugated hyperbilirubinemia that is of inherited origin. And it is the first one, Dubin-Johnson, characterized by conjugated hyperbilirubinemia. And there will be defect in this condition, not in the enzyme. The defect is in the excretion of the conjugated bilirubin. So it is uptake normally conjugated, but there is defect in the excretion. As a result, the type that increase is the conjugated. And it is characterized by presence of a pigment in the liver. The other similar condition, also conjugated hyperbilirubinemia, that occur secondary to defect in the excretion is due to the Dubin-Johnson syndrome. Similar to Dubin-Johnson is the Rotor syndrome, but it differs from it by being the liver cell is not pigmented in this condition. The liver cell is not pigmented like the Dubin-Johnson syndrome. In addition, other marker, we have increase in the urinary coproporphyrin in this patient. This case study will illustrate how can we use the information we gained from this lecture to diagnose certain condition For example, this patient, we have a 60 years old man presented with loss of weight, loss of appetite, which usually these two conditions when present together, sometimes it may give hint that this patient may have cancer. Then he started passing the dark urine for some time, and his stool were pale. We say that one type of jaundice, certain class, is characterized by pale stool because there is no stercobil gene. By examining the patient, in addition to his feature, he was jaundiced and he have a palpable mass in the right upper quadrant of the abdomen. And by testing his blood for certain marker, the bilirubin was increased. The albumin, which is a marker of liver synthetic capacity, is decreased. The alkaline phosphatase activity is high, and it is a marker of obstruction or cholestasis. The ALT, amylin transaminase, is normal, and the GGT activity, glutamyl transferase, gamma glutamyl transferase activity, it is also a marker of cholestasis, is increased. So in this condition, we have increase in the total bilirubin. The marker of cholestasis in this patient is increased. In addition to his clinical presentation, he said that you have pale stool and dark urine. All these features together give a hint that the patient have post-hepatic jaundice, and this may be due to, for example, a tumor in the liver or in the common bile duct or in the pancreas that cause obstruction to the flow of the jaundice of the bilirubin to the intestine. Thank you very much, and ready for any question.